About 5 years ago, we as mental health providers got a big slap in the face. And that report came out that basically said that people with severe mental illness were dying 25 years earlier than the general population. And that report went on to say that it wasn't that they were dying because of anything having to do with their mental illness, but they were dying from things like cardiovascular disease, untreated tuberculosis, respiratory diseases, conditions that are very preventable and very treatable. And a lot of that came down to the fact that on both sides, as ridiculous as it seems, it was almost like you come into a behavioral health center or a mental health provider, and in essence, it was kind of like, okay, bring your head in, leave the rest of you there at the door. Or the other side, it's like, leave your head at the door, bring the rest of you in. And we know that that's not helpful. And so the whole concept of looking at the whole person is the other, or one of the other big features of mental health care. And it's got to be. In many ways, it's going to be forced by the Affordable Care Act and whatever iteration that comes out in when it's finally settled. But the other part of that is it's just the right thing to do. If you don't have good physical health, you're not going to have good mental health. If you've got serious physical conditions, then you're going to be depressed, I guarantee you. I mean, one of the things that's becoming is at this point a practice guideline is that if somebody gets a diagnosis of cancer, there ought to be at least an automatic screen around depression and maybe a referral in terms of depression treatment. And vice versa the other way too. If you have a mental health condition that's pretty significant, there's chances are that you're going to also have physical health issues that need to be addressed. And so, there's also a big movement towards seeing the person as a whole person. Some of the big things also around that have to do with that are going to be really management of chronic conditions. And both mental health as well as physical health, chronic conditions. And that's something that the system is moving towards also. Finally, just in terms of, kind of paradigm shift in terms of treatment and services, and that is really anchored in the recovery movement is around control, personal control over one's destiny, in essence. And where that comes from is information, so that, okay, I've got this illness. What is it? How did that happen? And here's the treatment that you're suggesting that I do. How does that work? And how does that impact whatever's going on? And historically, we haven't done a real good job of providing that information. And all of us here know that if we are in the dark, we don't have much control. We are totally reliant on others. And people need personal control. All of us do. And then the other part is around skills. Again, these illnesses are so debilitating. It's not like folks maybe didn't have those skills at some point in time. Many did. But the illness is debilitating to the point that it tramps out that stuff. And sometimes those things need to be relearned or at least put out there so it's like, oh yeah. And so skills to be able to manage those illnesses and skills to be able to do other things like go to work, to be able to meet people, social skills, those kinds of things are the other big movement in terms of the recovery process. So real quickly, just shifting then to the second part of this is really, what does the system look like in the future? What does the service system look like? So from 2006 through 2010, there was a regional effort that took place within, and when I talk about regional effort, what I'm talking about is St. Louis City, St. Louis County, Jefferson County, Lincoln County, Warren County, Franklin County, and St. Charles County. That's what I mean by region. So regional effort, there was an embarkment on a regional effort, and basically the goals of that were to look beyond how the system had traditionally operated and to engage in a process of long-term problem solving and strategic planning and basically to overall improve the system of care for behavioral health disorders, mental health and addiction disorders. It was facilitated by the Regional Health Commission, really kind of the next step from the work that that group did with the safety net for primary care in addressing the crisis of losing Connect Care and some of that real crisis that we had in our region at one point with regard to primary care. And that was a process that went on for 4 years. And some of the things that came out of that was, and Francie kind of mentioned this earlier, was really there was an awareness, maybe for the first time, that there were really a relatively small group of folks, number of people, that were using enormous resources within the system of care. And many times these were folks that were homeless, these were folks that were, that had co-occurring disorders of substance abuse and mental health, all the things that Francie had talked about earlier. Just pausing for a second, just to anchor back to what Francie also talked about, both in the recovery, in terms of moving that forward, turning that cruise ship around, and in terms of the future of the system of care. Housing is fundamental. It is, it's the, going back to Maslow, you gotta have a place to live where you feel somewhat comfortable and it's a place. If you're out there on the street, you're homeless, or you're doubled up, or whatever, all of these things become almost insurmountable. But we were able to do through that process, we said, wow, there's these, there's like, X number of people out there, and they're using up, maybe 50% of the resources. How can we target those folks? What is it that those people need? That could start to free up some resources. There was also things around access to care, recommendations around how do we increase access to care, and then also stigma reduction, which is huge and it's big and it's powerful and it's very potent. And it impacts the system of care for mental health. Probably the greatest things that came out of that 4-year process was, there really was a discovery, I think, on the part of folks who were involved. And the people that were involved in this process were behavioral health providers, mental health providers, substance abuse providers, federally qualified health centers, departments of health both in the county and the city, as well as advocacy organizations like NAMI and Mental Health America. And what we recognized was, wow, there really are other people who are very committed and very talented and care a lot about what happens in this region in this regard. And hey, if we work together, there's some things we can get done. Probably a little bit more than we could have done if we tried to do it on our own. So that was one thing. The other thing was, it began a process of mutual trust within each other. Coming together like that over that 4 years, there started to be some degree of mutual trust. And that's always hard when you think about collaboration and you think about, okay, how do you do that? That issue of trust becomes a big piece. And I think that was one of the huge accomplishments that occurred through that 4-year process. The idea for the future system of care really has got to be one that is 4 things: accessible, effective, efficient, and accountable. Okay, so when we